Good evening, everybody, and thank you so much for joining Simania Clinic today. I hope you've enjoyed the public holiday. Happy Freedom Day. So, the topic that we're going to discuss today will look at a scientific perspective to the COVID-19 vaccine. Our guest speaker is Malefu Moleleki. She is a medical scientist with more than 9 years of experience in the field of medical microbiology. Her PhD focuses on exploring new and interesting technologies for the diagnosis of bacterial pneumonia and meningitis. She is passionate about teaching, and her goal is always to create a nurturing environment which transforms complex scientific concepts to simple, easy to digest content that is accessible to learners at different levels of their development. Her advocacy for vaccination predates the current COVID-19 era, as she strongly believes that people who are targets of vaccination campaigns should be armed with the knowledge on how vaccines work and why they are needed so as to allow for informed decision making. She understands the important role that scientists have to play in this regard. Thank you so much, Malefu, for being here tonight. Over to you.
Thank you, Kim, for that wonderful introduction, and a good evening to the viewers. Thank you so much for inviting me today to speak on this very important topic. Particularly now in the era of misinformation, it is absolutely important that the people with even the basic knowledge of what is going on to take advantage of platforms such as yours in order to at least make corrections or give out the correct information with regards to the pandemic. It has really affected every single one of us, and it has hit us at our very own core. And we have, as of today, we have over 140 million cases that have been confirmed, and more than 3 million deaths due to the pandemic. On top of that, we are all aware of the disruption that the pandemic has had on our healthcare facilities, on the economic activities. Just the mere thought that there is limited movement nationally and locally has had a devastating effect on world economies. And so it is very important that we found our way out of this, because it's going to take years and years just to recover from this catastrophe. So now the question is, how do we do that? How do we get to the point where economies can open up, we can ease the burden on healthcare facilities, and most importantly, we can prevent deaths? The simple answer to that is that we must find a way to stop people from getting sick. If a large proportion of the population is immunized and they're not getting sick, then we have a shot at controlling transmission of the disease, and therefore the ability to open up all these economies and to also ease the burden on our healthcare facilities. And vaccines are a way to do that. So today I wanted to come here to talk about these vaccines. My take-home messages will be for the audience to walk away having a basic understanding of why do we need to vaccinate and how these vaccines work. So I came across a survey online. It was of about 12,000 adults aged over 18 years. And it was intended to gauge people's perception on whether or not when a vaccine is made available, they will get vaccinated. And to my surprise, majority said yes, they will get vaccinated, although some of them were a little bit reluctant. So as an example, in South Africa, 65% of the participants said yes, they will, somewhat reluctantly, get vaccinated. This is a great number. However, in order for us to be able to block transmission of disease and get past the pandemic, this number needs to go up. And so it is important to understand why only 65% of the population is open to the idea of getting a vaccine. What are the reasons that the people are not willing to get vaccinated? So they did another survey to gauge this reason. And the reasons ranged from I am worried about the side effects. I'm worried that a vaccine is moving through clinical trials too fast. I'm against vaccines in general. I don't think it will be effective. The risk of me getting COVID-19 is low, and then other reasons. But generally, the two main reasons were that people were scared. There was a fear and a mistrust of the vaccines because of the idea that they might get terrible side effects. And also that because the vaccines were developed in such a short space of time, there has not been enough time to monitor their safety. Again, goes back to the concerns about the side effects and therefore the fear that the side effects may not be worth it. So this brought this quote to mind that knowledge is the antidote to fear. If we can provide the knowledge and the basic understanding of how vaccines work and why we need them, perhaps we can shed some light and ease people's fears with regards to their safety so that when we're speaking side effects, then people are looking at it from the point of view of knowledge and not that of fear. So why do we vaccinate? Vaccines, since the inception in the 17th century, have been the most successful method of successful public health intervention against infectious diseases. We use vaccines to prevent childhood diseases. We use them to control deadly outbreaks. We also take vaccines when we travel to disease endemic areas. And at times after injury, we take vaccines to prevent tetanus. And then in the era of COVID, in the era of the current pandemic, we also need vaccines in order to decrease or block transmission of the disease within the population. This is this concept that we refer to as herd immunity. In basic terms, herd immunity refers to the idea that if a large proportion of the population is vaccinated against COVID-19, then they create a protective blanket against those who have either not been vaccinated or they have been vaccinated, but they were not able to mount the correct or the effective immune response against the disease. So by blocking transmission, so by creating this herd immunity, it means the vulnerable people are not getting infected. But for this to happen, it requires that a huge number of the people in the population are vaccinated. So for COVID, it was calculated that herd immunity will be attained if 60 to 75% of the population is vaccinated against COVID-19. Now, this 60 to 75% number is a mathematical calculation if using a highly efficacious vaccine that is close as possible to 100% efficacy. Now, when we're talking about vaccines with low efficacy, this number has to go a little bit higher. If the vaccine is shown not to be efficacious or as effective as it should be, then we will need to vaccinate a much bigger portion of the population in order to block transmission of the disease to the point where most likely the entire population may need to be vaccinated. Vaccines also can protect against severe disease, especially in individuals who are at high risk of severe disease. So by doing so, preventing hospitalization, so easing that burden on our healthcare facilities, and also preventing death. As we're talking about vaccines, the COVID-19 vaccines, it is important to get some basic understanding of the virus itself so that we understand what these vaccines are and what they are targeting on the virus. And then when we're talking about immune response, effective or not effective, we have an understanding of what it is we're talking about. So we've seen this picture a number of times on social media or however you have come across it. It depicts the virus as this circle with the spikes coming out of it. So the virus in this picture has been cut open, and you can see the little springs inside of the envelope. Those springs represent the RNA of the virus, or the genetic material as we would refer to it. So the genetic material carries information on what the virus is able to make. So RNA and DNA are sisters. We know as humans that DNA is the thing that carries the genetic information to say, oh, you're black, you're white, you've got straight hair, you've got curly hair, you've got coarse hair, you have long feet, you have short feet. It's essentially the same with RNA. It carries the genetic information to say this virus is going to have this spike, is going to have this component here, that component there. So of the components of importance that is encoded in this RNA is the spike protein. So the spike protein is depicted here as the spikes that are coming out of the virus. And the virus uses these spikes when it enters the human body and then it enters the human cell. It attaches onto a human cell using these spikes. And then the cell takes the virus inside. When the virus enters the cell, it hijacks the cell to make the cell to make more copies of itself. And then when it makes more copies of itself, the virus then leaves the cell, and that's how an infection occurs. So the spike protein plays a very important role when it comes to COVID-19 and how the disease occurs. So before I go on to talk about the vaccines, I must also just highlight that this spike protein is very, very important when we're talking about vaccines. But not only that, we've been hearing about SARS South African variant, the UK variant, the Brazilian variant. Again, we will see how important the role of the spike protein is when we start talking and defining these variants. So just a little detour before we go on to talk about the vaccines. There have been a number of variants of concern that have been reported with regards to the virus. So we know of the original Wuhan strain that emerged in mid to late 2019. But then in January to February 2020, there was a new strain that was identified. It was called the D614G lineage, and it became the predominant strain globally by June 2020. When scientists had a closer look at this strain, they found that the strain had some changes in the spike protein. Remember, I said the spike protein is like the MVP when we start talking about COVID-19. So they found that there were changes on the spike protein. And when they looked further, they saw that these changes made the virus, when it enters the cell, the human cell, to make much more copies of itself than if one was infected with the original strains. And so it gave the idea that these changes in the spike protein made the virus to make more copies of itself, therefore a higher viral load. And we know that if you have a high viral load, then it makes it easy that one can pass the virus on to the next person. So hence, the higher the viral load, the higher the transmissibility of the virus. Then A few months later, in September 2020, we heard of reports regarding the UK variant. And when they had a look at the UK variant, they saw that it also had changes in the spike protein, but the changes were slightly different from that of the D614G lineage because they occurred at a different position. However, the changes were enough to mimic the effects of the changes that occurred in the D614, which meant that this variant was also associated with a higher viral load and therefore was easily transmitted between individuals. They realized that these changes made the virus to be able to adhere or to bind a little bit firmer onto our receptors, therefore making it easier for it to enter the human cells. Then about a month later, they identified yet another variant. It was very similar to the variant they identified in UK, but this variant that was identified in South Africa in October 2020 had a few more mutations or had a few more changes that were enough to make it a little different from that one identified in the UK. But then when they were looking at its properties, they realized that these changes too allowed for the virus to make much more copies of itself than the other strains, and therefore it was more transmissible. And this is the variant that we are concerned about as people based in South Africa and ultimately in Southern Africa. To have an even better idea of how this variant affected the epidemiology of COVID since the first case that was reported in March last year, we will look at how the number of daily cases since the beginning of the pandemic until sometime in February this year. And we know that we've had 2 waves so far. And we know that the second wave hit us a little bit harder than the first wave. Yes, the second wave hit us harder. It may have been for many reasons, considering that the second wave occurred around the festive season, and we know the festive season, perhaps our behavior was a little bit more relaxed, and so it made it easier for us to pass the virus around. However, one cannot ignore the fact that this spike in cases also coincided with the introduction of this new variant. And so it is safe to say that even if the second wave was to occur because of our poor behavior during the festive season, it was also driven by the fact that we now had this new strain that was a little bit easier to transmit between individuals. Hence, our case numbers peaked to about 22,000 a day compared to the first wave where the highest peak was 14,000 cases a day. So coming back from the detour to come back to speak about the vaccines, I mentioned that spike protein is the MVP of the virus because of the important role that it plays for the virus to gain entry into our human cells. Also, you will notice that the spike protein is the one component that is sticking out the most when compared to the other components of the virus. This means that it becomes the first point of contact with our immune cells, our immune system. And therefore, it made sense that different vaccine manufacturers then targeted it as a target for their different vaccines, because, as I said, it is the first point of contact with the immune cells. They have done this by using different formulations. And today I will speak on the 2, using mRNA vaccines or using vector vaccines. At the moment, there are about 300 vaccines that are in development. More than 70 of them are in clinical testing, while about 10 of them have been approved by the major agencies in various regions of the world. So how do these vaccines work? Well, manufacturers make the vaccines to mimic parts of the virus. And when the vaccine enters the human body and mimics the virus, and if It is a vaccine that is made of the RNA. Remember, I said the RNA carries the genetic information that says what is on the virus. And so the manufacturers have designed their vaccines such that they take a small portion of that RNA, the one that codes for the spike protein, and then they use that to make the vaccine. So they don't take the entire thing because we don't want to get sick from the vaccine. They only take a small portion of it while the rest of it is left behind. That way, the vaccine itself will not make you sick because the vaccine will only have the information that says make spike protein, but not everything else. So they can package this as either the RNA as it is in its naked form, or they can put the RNA inside of a harmless virus vector, and then they inject this into the human body. So if the vaccine contains the mRNA, then it uses the human cell to make the spike protein from this mRNA in the vaccine. Your immune cells will notice that this spike protein is foreign. It's not something we are used to encountering in the body, so it must not belong. So we know that our immune system is intended to get rid of these foreign bodies. So it will make antibodies and other cells to attack this spike protein. In the process, it will also make memory cells to remember the spike protein in future infections. And so next time when you get infected with the real virus, your memory cells will remember the spike protein that we know that is on the surface of the virus. And then it will say, this is that enemy that we have come across before. So therefore we must attack and get rid of it, which makes the immune response a little bit faster. This is what we refer to as immunity. And I have depicted it in this diagram on our right. So we have our virus there with its little spikes. And once you are vaccinated and your body has made these memory cells, then when the virus enters the body, then your immune system will recognize the spike protein on the virus, and then it will tell your cells to make the antibodies that are targeted against the spike proteins, and then the antibodies will surround the virus either to kill it or at least at the very least to make it harmless such that the virus is not able to enter your cells and therefore cause infection. So as I said, there are about 10 vaccines that have been approved by various agencies. And of those, I will speak on the 5 that are the biggest names that we're talking about at the moment. So the first one being the Pfizer. It is an mRNA vaccine, as I've described in the previous slide. And again, it targets that full-length spike protein, as I mentioned. And then also the vaccine carries these modifications on the spike protein, which are said to have the ability to make our immune response a little bit better. We have the Modena vaccine. It uses the exact same target as the Pfizer vaccine and therefore the same immune response. So you could say Pfizer and Modena are twin sisters. We have the controversial Astrazeneca vaccine. It uses a vector. Remember, I said the vector is a harmless virus that happens to carry that small section of the RNA of our SARS-CoV virus that encodes the spike protein. So that small section of the mRNA also, like I said, it carries information to make the spike protein, but it doesn't have the same modifications as the Pfizer and the Modena. So it means that even your immune response to it will be slightly different. So I guess you could call them cousins. Then we have the Johnson & Johnson, uses a vector vaccine like the AstraZeneca. It targets the S protein. It also has those modifications by Pfizer and Modena, but it also has additional changes on the, or modifications on the S protein. So it is not expected then to have a same immune response to any of the virus, any of the other three vaccines that I've mentioned, just because of the differences in how they have designed the parts that encode the S protein. But when they tested it in the lab, they did find that it did have some similarities in the immune response as the Astrazeneca. So you could call them sisters. It has been approved for emergency use, as we know. Then last but not least, we've got the Gamaleya, the Sputnik from Russia. So it also uses it's a vector vaccine, but unlike the other two, it uses two different types of vectors. And it is shown that when they use these different types of vectors, it makes your immune system to be a little bit stronger and it lasts longer. And it targets the full spike protein. It doesn't have any of the modifications that I've mentioned above. But because it uses two different vectors, it also doesn't share the same properties as any of the other vaccines that I have mentioned already. So it has its own unique immune response. So in a sense, there are some similarities, but there are major differences between the different viruses by the different manufacturers, which makes it very interesting and difficult when it comes to the choice of which vaccine to use. So I've put together this table just to kind of try and break down what to look for or what information is necessary when making a decision on which vaccine to use. So one would look at what type of vaccine is it, and to look at so far who can receive the vaccine. That is, in what population has the vaccine been tested such that we can safely say this vaccine will be effective if we were to give to this population. Also, looking at the number of doses, whether you would require a single dose, two dose, or even booster doses at a later stage. We'll look at the efficacy of the vaccine. How effective is the vaccines in preventing disease? We also cannot ignore the efficacy of this vaccine against the new variants, because we have had stories that, or reports that these vaccines are not as efficacious against the new variants as they are against the old ones. So that's also another thing to take into consideration. You look at the what is causing disease among your population, which variant is causing disease among your population, and you use that information in order to decide which vaccine will be best suited for the virus that's circulating amongst the people. From the logistic point of view, especially in our low income countries, you have to take storage requirements into consideration as well. And then I'll look at cost and availability. And availability, we're talking about whether governments can have access to the vaccine, or will it only be available using partnerships. So for just generally, when we're talking in terms of doses, Johnson & Johnson is the only one that is given as a single dose. And then when we're talking efficacy, all of the vaccines were very efficacious against the old strains, but then with the new strain, they have lost a little bit of that efficacy, although some studies are still carrying on in order to see just how much of the efficacy has been lost. And the good news is that even though the vaccines have been shown to have low efficacy against mild to moderate disease, they have shown good protection against severe disease and death, which ultimately is important. If at the end of the day we get sick, but we don't need to get hospitalized and we don't die from the disease, that is also a win for us. And then when we're talking in terms of distribution, it becomes harder to provide ultra cold storage. So it is actually preferable that vaccines are kept at are easily stored in the household fridges, which, as I said, is important in our low-income countries. And then cost, the cheaper, the better. Availability, as I said, the more available, the better. So these are the things to take into consideration. And then when we're speaking of South Africa, what is the landscape in South Africa? What is the rollout plan? Like I said, I spoke about herd immunity, about needing to immunize a large portion of the population in order to block transmission of the disease. So in South Africa, this was calculated to be about 67% of the population, which is about 40 million people. Now, so this is going to be done in 3 phases. The first one targets healthcare workers. Second one, essential workers and people at high risk of severe disease and death. And then the third phase is everyone else. And this was intended to be done by the end of 2021. So at the moment, we know that we received the 1 million doses of the Astrazeneca vaccine in February, but they were quickly taken out of the rollout plan because it was shown that the vaccine was not efficacious against the South African variant. We have, so the government has also secured 12 million doses through the COVAX facility, and then 9 million doses through Johnson & Johnson, of which the Sisonke program is using to vaccinate healthcare workers. And then the government has also secured a number of doses through Visa as well. And all of these are expected now in the second quarter of the year. But the question remains, will it be enough to reach the majority of the population as expected? When we're looking at the current doses given compared to the world, only 0.5% of the population has been vaccinated. So that leaves still about 66.5% in order to reach this herd immunity by the end of the year. Will this be possible? Perhaps, or perhaps not. So far, there have been major delays in procurement of the vaccines. We know because of we had to discontinue use of the Astrazeneca vaccine, also delays in the phase 1 trial of the Johnson & Johnson, the Sisonke trial, because of concerns over blood clots as adverse events. And then basically, in order to reach that 67% herd immunity, South Africa will need to vaccinate over 200,000 people a day, excluding on weekends, until the end of December, which may not be such an achievable goal. And again, it doesn't help that procurement is only done through government because the private sector is unable to secure manufacturers. So this is becoming a bit of a problem. So at the end of the day, we need a vaccine that is highly efficacious, particularly against these new variants. And so this can be something that is ongoing, depending on how the virus evolves. We need to administer vaccines to prevent hospitalization and death in the short term while we're waiting for those highly efficacious vaccines. And we must prioritize individuals who are at risk of severe disease. We still need to stick to the non-clinical interventions, such as wearing our masks, sanitizing our hands, and social distancing. And South Africa needs to look at improving capacity for local manufacturing of vaccines, which is currently non-existent. So there are a number of questions that are pertinent with regards to COVID-19, but I think in the interest of time, I will skip through this and I will open that to the viewers and listeners to ask me. Thank you very much, and I hope you found this presentation useful. Again, thank you, Kim and Mariba, for the invitation. Over to you, Kim.
Thank you so much for that conversation and for really teaching us in terms of what the vaccine is and how it works exactly. I mean, for myself, it's now crystal clear as to why we're utilizing the Johnson & Johnson vaccine. We currently have Babu with us. I'd like to find out if he's got any questions at this moment. Hi, Babu.
Hey everybody, good to see familiar faces.
Yes,
Hi
good to
Malefu.
you.
That was
Hi, Babu.
that was great. I'm sorry I was struggling to join in. Maybe the only question that I have is my biggest worry is the current events in terms of AstraZeneca and the Johnson and Jones. How is how is the population receiving the news and how are they digesting it? There was a lot of skepticism before even those events. Just wondering to know if there's any development on the ground. Mm.
Yes, obviously the public perception will be negative with regards to all these disruptions. However, I don't know that it has been negative to the point where people have actively said, no, I will not go get vaccinated because of all of this that's going on. I think it has created a lot of negativity in the social media and whatnot. But I don't know that we are at the stage where we can assess whether or not people's perception on whether they're going to get vaccinated or not has changed. Because remember, at the moment, our vaccination campaign is purely on health workers at this time. And so healthcare workers, I think, they have been a little bit less hesitant when it comes to getting vaccines, just because I think they have been exposed to the devastating effects of the disease itself. And so getting some form of protection, I think, has driven people to say, you know what, it's fine, let me get vaccinated. So I don't think at the moment we're at the point where we can safely assess that, yes, the people have decided they're not getting vaccinated because the vaccine is not yet out there to the people.
Mm-hmm.
Oh yeah. No, thank you very much. That was well put. Maybe a point I can add is that you know, as scientists, we make vaccines, but vaccination is a social
Absolutely.
social scientist work. So we need to
Absolutely.
bring on board social scientists, and those are the people who will drive
Absolutely.
the vaccination. Yeah.
Absolutely. I was thinking exactly the same thing. We with the Johnson and Johnson and with the AstraZeneca, with the adverse events with blood clots. I don't know if you've noticed this, but as the regulatory bodies were opening up rollouts of those vaccines, the underlying message, if just think of one or two articles you came across, it was the benefits far outweigh the risks. To a scientific person, you know exactly what that means, and that makes sense. But to a lay person, it is in the way the message is portrayed to say that those people who got blood clots and those 10, 20 that died, they don't matter. So we need to be very careful in terms of how these messages are packaged, because that is not the case. What you it's fine to say the risks are low, but what you don't want is for people to feel like you're saying, oh, even if I go and I die, it doesn't matter because I'm one out of 7-8 billion people. That's the message we must avoid. So yes, this is the point where our social science people need to come in and correct the way in which the message is being portrayed.
Dr. Lebeko, any questions from yourself?
Yes. Thank you, Malefu, for that brilliant presentation. I've got quite a few questions, but I think we still need to be cognizant of time. So we're hoping that we can wrap up this in about 7 minutes or so. Okay. So the first question I've got is, I think you went into quite nice detail about 5 of the 10 vaccines that have been approved for emergency use by the WHO. And just my question, I think, which might be important to the audience is, which of these is South Africa going to have access to? Do we have knowledge of which ones we are going to get?
So there was a slide where I did show which ones South Africa is currently working with. So remember I said so the AstraZeneca has been out of the question. So the Johnson & Johnson, because it was shown that it is efficacious against our variant, even though the efficacy is low, but it's still better than what's currently available. Pfizer as well. They're also going to procure vaccines through the COVAX facility. And the COVAX facility has its own vaccines. But remember, the COVAX facility is not catering for South Africa, it's catering for partners within that facility. So the COVAX facility has AstraZeneca, it has the Sputnik 5. Once the Sputnik 5 has been approved by the WHO, which it hasn't just yet. So the Sputnik 5 has been approved by, I think, regulatory bodies in Russia, but not so much the WHO, not even the European agencies, not by the FDA. So it's still a little bit off before it can even reach that stage. But it is part of the vaccines that the COVAX facility was looking at procuring. So South Africa will procure some of those vaccines through that facility. But outside that facility, we've had of the Pfizer, we've had of Johnson & Johnson.
Okay, all right. So you also gave us quite a nice overview with regards to the number of cases, the cumulative number of cases since the beginning of the pandemic in March, up until maybe somewhere around February 2021. And in that graph, there's a very clear or distinct two faces of the number of cases. So using that data, do you think we can be able to preempt the possibility of the third wave? Judging from how the first and the second wave occurred, and I'm saying the possibility because we can't say for sure. But can we use that type of data to say, in about 4 months' time, we might encounter a third wave?
So, from the scientific perspective, it is possible to project the likelihood of a third wave, but this is a modeling question. So they use mathematical models in order to predict if and when the third wave will occur. Based on previous reports before the Easter holidays, it was suspected that we will likely go into the third wave around the Easter holidays just because of activities during that time when schools are closed. So there's a little bit more interaction between people. So there's a lot more to take into consideration. But yes, it is possible to predict the epidemiology of the disease by using mathematical models, but that's there's a very mathematical statistical projection.
Okay, all right, thank you for that. So then another question I've got is, what I've seen is that most of the vaccines are made against the spike protein. And, what we have seen is that the mutations actually happen within specific regions or various regions in the spike protein. So what I've seen is possibly South Africa and many other countries have actually acquired the vaccines based on that platform. In terms of the vaccine acquisition strategy, how wise is that?
These are the vaccines that, remember, are currently available. And there are vaccines which are targeting other aspects of the viruses, and those are still in development. And when the data from those studies is available, South Africa will be in a position to make the decision of whether or not to go with them. But obviously, the efficacy has to be tested against the circulating variants in order to make that call. The call to acquire those that were targeting the spike proteins is because those were the ones that were available in the current market. That's my assumption. And to me, that seems practical.
Okay, all right. So the other question, we have seen from the data, I think recent data, that the Johnson & Johnson, the vaccine trials were done in the UK, in Brazil, and also in South Africa, right? And then there was varying efficacy depending on the geographical location. So looking at the South African setting, the vaccine efficacy was about 57%, right? And earlier you mentioned that for acquisition of the herd immunity, we need to have a highly efficacious vaccine. So now looking at the 57% efficacy and seen that Johnson & Johnson is the only vaccine that we have currently.
Mm.
What is your take with regards to us vaccinating 40 million people, which is about 65%, and actually attaining that herd immunity, judging from that low efficacy, and
yes, okay.
putting a spanner to the whole thing with these emerging variants?
Mm-hmm. So I missed your last point. Putting the spanner to the whole thing, we have
the emerging variants, you know.
Okay.
Yeah.
So the Johnson & Johnson trial occurred, I think sometime in the era that also included the new variant, hence the low efficacy.
Yes.
So it is fair to say the data that we are seeing with regards to the Johnson & Johnson efficacy in South Africa, it is directly linked to the new variant, just because that's what was circulating during that time. So at least we can get that out of the way. And then in terms of herd immunity, I say that one of the things that drive a herd immunity is how efficacious the vaccine is, and it has to be as close to 100% as possible in order to reach that herd immunity. Herd immunity is a mathematical calculation, so the efficacy of the vaccine will have to be factored in order to attain a value. So the value of 60 to 75% was used based on, one, the transmission of the disease in the population, and also how highly efficacious the vaccine is. So the lower the efficacy of the vaccine, the higher the proportion of the population will need to be immunized in order to attain efficacy. A vaccine that's efficacious at 57% would mean that in order to attain herd immunity, you would have to vaccinate possibly more than 75% of the population in order to reach herd immunity. But remember, the efficacy was measured against mild to moderate disease. That is, people getting sick. But the real or the bigger picture is that we don't want people to get severely sick, and we don't want people to die from COVID. And it was shown that even though the efficacy of the vaccine against mild to moderate disease was low, it was still very, very protective against severe disease. And so that's the benefit. You have to look at it from that point of view. And so attaining herd immunity may not be a very near goal, but in terms of preventing severe disease, that's a much more achievable goal. So it means that the vaccine in its current format is still useful and effective in the fight against the pandemic. It's just that we have to be realistic that it will not prevent us from getting sick, but at least we won't die and we won't get hospitalized when we do get sick. That's the most important factor.
Okay. All right. So last one. One of the major driving forces, I think, with regards to vaccine hesitancy is linked to the normal or the conventional time that the vaccine takes for it to be fully developed. So normally we're looking at, plus minus 10 years of development for the vaccine to be able to be put out there. So now this has been done in terms of SARS-CoV-2. This has been done in under 2 years. How do we explain that, to the general public? How did we attain that? And what sort of assurance do we give to the general public that this is safe in as much as it took this little time to develop?
Because of the pandemic and the urgency in getting to a vaccine, that in itself justifies the speed at which the vaccines were developed. It does not mean that in terms of the clinical trials, corners were cut. No, the vaccine development process still occurred in all its phases. So in the lab, and then once in the lab, out of the lab into the clinical setting. So all the phases were done accordingly. It's just that now things were done at a higher speed than before. Remember that the safety of the vaccine is monitored throughout the clinical trials. We have your phase 1 trials, small population, you want to see that the vaccine is safe, and you want to see that it does evoke a strong immune response. You have your phase 2 trials. Again, the phase 2 trials, you're still looking at safety, and you still want to see the effectiveness of the vaccine, but within a larger group of people. That was still done. You do your efficacy trials, phase 3, still safety is a concern, and you're still now enlarging your study to incorporate a larger population, so more than 2,000 participants. That is still being done. The difference is that now it's been done within months, whereas before it was done over years, but it is still being done the right way. So at the end of the day, data coming from that still has to go through the the regulatory bodies. It still has to tick all the right boxes before it can be approved. So while certain corners would have been cut in terms of time, but in terms of doing things the right way, that has still needs to remain possible. And that's why the regulatory bodies are playing as the watchdogs to make sure that this is being adhered to. So it's understandable for people to be hesitant, but at the end of the day, as I said, the regulatory bodies will still need to check the boxes to make sure everything was done accordingly.
Thank you so much, Malefu. Yes, Babu?
Yeah, if you have a minute, I would just like to touch on that. So the biggest driver of hesitancy has been the turnaround time, as we've spoken. But beside the money, the funding availability, and everything else, we also need to consider the nature of COVID. One, there was availability of disease. So if you wanna develop a vaccine, first of all, you need to factor first how quick COVID was around. So if you get infected today, in 10 days time, you have the symptoms. Whereas if you take TB or HIV, the biggest diseases, it takes months for a person to show symptoms. So it was easy for scientists to have a large pool of samples to test. And also there's also the sample availability. So we had millions of people around who had COVID. So it was easy for scientists in the lab to get a large pool of samples for testing. And also considering that COVID takes about 10 days for a person from getting the infection to the disease. So that also what drove the speed around. So when people talk about HIV and TB or the chronic diseases that we've been having for years and years, they must also consider the time that it takes from infection to the disease showing.
Thank you so much, Babu. Thank you. Dr. Libeko?
Yes, I think Malefu and Babu, those are really important aspects to addressing the issue of time to the development of the vaccine, because I think it's a major thing with regards to vaccine hesitancy. And thank you for clarifying that. Just adding on to that, it's also what gave the vaccine development fraternity power also was information sharing. Most of the time, in terms of vaccine development, people undertake this development in their own because of IP protection and all those things. But now information was shared amongst scientists globally. So on top of availability of samples, on top of the nature of the disease, there was increased funding to support vaccine initiatives. There was also increased collaboration between different institutions and different bodies globally. So that really pushed, decreased the time that that vaccines normally take for development. And I think it's an important aspect that you unpacked for today. So I think thank you very much, Malefu, for all that. Dr. Kim, I don't know if you've got anything.
Yes, no, definitely.
Close up.
Thanks so much, Dr. Libeko. One thing that I noticed that you spoke about right in the beginning, and I think it's a key phrase for everyone to take home tonight, is that knowledge is the antidote to fear. So in terms of the vaccine that's now being rolled out with healthcare workers, the second phase is that it's going to be rolled out to the elderly. How do we improve the message for the elderly that this vaccine is indeed safe for them to use, and how do we improve health education around that? What are the strategies that could be potentially used at this point?
So Kim, I can leave this for everyone in the meeting to respond. What we're doing right now is, again, a show of how these messages can be communicated to people, where we take this very complicated concept and we break down.
Oh no, I think a network is a problem. Dr. Libeko, do you want to assist?
Yes. So as Malefu was mentioning, using various platforms to educate one another is one of the key aspects to addressing vaccine hesitancy. And I think we need to use the same platforms that misinformation is being disseminated through, such as your social media platforms, your Facebook, and many other platforms. So we actually go onto the Facebook and deliver accurate messages as a scientific community. So we must address, those problems. So also looking at, health education, using various platforms and all that. So I think that's really important that we do that. So that's basically what is important to address vaccine hesitancy.
Thank you so much.
We've got Malefu back.
Yes. She's still connecting to the audio. Hi, Malefu, can you hear us?
With this online things, the internet can just cut just like that. I'm connecting through my phone. Just to address your question quickly, Kim, I was saying that what we are doing now is an indication of what it is to share information, to make it accessible to everyone. That we take in these complex scientific facts and we're breaking them down so that people can understand. And that needs to happen on a national level as well. We need to target our populations and relay the information using media that is accessible to different people in order to get the message across. Because as you said yourself, the more knowledge people have, the easier it is to make decisions whether or not they will take the vaccines, but they will be making decisions based on some basic understanding of what it is that they are taking or they are choosing not to take.
Thank you so much, Malefu. Closing remarks from you, Babu, or any remarks in this regard?
Yes. No, this is, it's very important. But maybe one last word I'll say is wearing a lab coat or wearing white looking as I am, doesn't mean that you have to take every word that I say. We've seen a lot of professionals coming out and delivering information that's not accurate. So I'll encourage people to use their closed social network. Someone who's a doctor or a scientist in your circle, ask them, be proactive. Don't take any message from a person wearing a lab coat. I mean, doctors get it wrong too. Yeah.
Thank you so much for that, Babu. Over to you, Dr. Libeko, to close.
Okay. Thank you very much, everyone, for such a wonderful contribution and such an inspiring talk, Malefu. We're really grateful for your presence with regards to just enlightening the broader community with regards to vaccinations, to vaccines. And I think you've touched on very important points. And as you said, the key take-home messages in the talk were, why is it that we need to vaccinate? And also, what is the importance of vaccination and what do we get from vaccination? And I think you've mentioned it, you've made it very clear that, to take care of specific diseases and to reach some specific immunity or herd immunity, it is important to vaccinate. And also, I think from the discussion platform, what we have picked up is that, gaining or having access to information is key, and it really drives the efficiency of vaccination. So the more people know, the less hesitant they will be, and the more acquisition of vaccines that will happen. And with more acquisition of vaccines, then we'll be able to attain that herd immunity. And with that increased herd immunity, then we'll be able to combat this pandemic, which is SARS-CoV-2 or COVID-19. So with all that said, I thank everyone for such a tremendous contribution. And I'll let Dr. Lamont just to close us off. Thank you very much.
Thank you, everyone, for joining in tonight. Thank you again to our guest speaker. We definitely have to have you again. I know the time was very short, but the content that you delivered and the simplistic manner in which you delivered the information really made it easy for anyone in the audience to understand what the different vaccines are about and how a vaccine works. So we truly appreciate your time. As Charlotte Matseke says, and since it's Freedom Day, it seems fitting, she always says that the work that we do is not for ourselves. We need to kill the spirit of self. And once we are able to kill that spirit of self, we are better able to assist others. So thank you so much for everyone participating. Have a wonderful evening further. Good night, everyone.
Thank you, Kim, and thank you for having me on board. And I look forward to future interactions with you all. Thank you.
Thank you,
And
everyone.
good night.
Good night.